So the first is to reframe. So you want to bring the patient and the family to where you're at in that moment. So they might be thinking about like, I'm going to get better and I'm going to get more chemo and I'm going to be like walking.
All right, welcome to eShadowing. Dr. Michelle Walter, thank you so much for joining me today.
Thank you for having me, Dr. Gray.
I'm excited as we get started here, as the students roll in. Let us know, for everyone coming in, where you are watching from and where in the process, this crazy pre-med med school process you are. Are you a freshman, sophomore? Are you a high school student? We often get high school students coming and hanging out with us. And if any of you have any interest in hospice or palliative care medicine, that would be awesome. Let us know in the chat. Dr. Michelle Walter, you are a hospice and palliative care physician, med-peds trained, which is this random specialty that I don't think a lot of people know about, this combined specialty. When did you first realize that you couldn't really decide, do I want to do internal medicine? Do I want to do pediatrics? Oh, wait, I can't do both.
That is a great question. And, you know, I fully intended when I was starting medical school to do pediatrics. I love kids. I spent, you know, my summers being a camp counselor and babysitting and, you know, all of that stuff. So, again, you know, fully intended to do peds. And then, of course, life happens. You go on rotations and you realize that you like a lot of things. I think that's a common theme on this podcast, that folks change career paths from when they started. So I really, really enjoyed other rotations. And I spent my first 2 months of clinical rotations as a third year with a med-peds physician. And it was a full 8-week rotation. And during that time frame, she, you know, spent time in her clinic. She rounded in the hospital with the teaching service. She worked at a clinic for developmentally disabled persons. So she was their primary care doctor as well. And I thought that was amazing. I thought that was really awesome that she was able to do all those things. So that was really formative for me. And then, you know, continuing on, aside from surgical specialties, which were clearly not for me and not my interest, all the other rotations I really liked. So thinking about applying for residency, I didn't want to limit myself because I really didn't know what I wanted to do. So med-peds was the answer because you could specialize in anything almost that's not surgical. Doing med-peds. So I felt like my opportunities were limitless.
Yeah. I know you have a presentation, but I have to ask this question, then we'll jump into presentation. And if this is part of your presentation, just say, shut up and we'll jump into your presentation. Med-peds is this like amalgamation, if that's the right word, of again, internal medicine and pediatrics. Why do we need that specialty? Why do we need a whole separate residency for med-peds trained physicians? Why not just have the internal medicine people and have the pediatric people? What is the goal of both?
I'm going to talk about that.
All right. So shut up. All right, here we go. Right. Go ahead and let's jump into your presentation.
Okay. All right. Let me see if I can figure this out and do this right.
And we do have some high school students here, at least one. I see Nidhi, who's a high school junior.
Awesome. All right. Are we good? Everyone can see?
Yeah, that works.
That works? Is it on presentation mode?
Yeah, we see your presentation mode, but it's...
All right. How do I fix that?
It's good enough. Usually presentation mode shows up. Do you have multiple hide presenter view, slideshow?
This is where I struggle. Maybe this. Let's try that.
Boom. There we go.
Better?
Perfect.
All right. So, okay. So, hi, I'm Michelle. I work at Roswell Park Comprehensive Cancer Center doing palliative medicine. And I'm also the program director for a hospice and palliative medicine fellowship. So very involved in academics and trainees. So as I already said, my journey to, I think I skipped ahead. Okay, so I'm from Buffalo, born and raised here. I knew that I wanted to be a doctor, and I don't know why. I really don't know why. There's no one in healthcare in my family at all. But I remember from a very, very young age that I wanted to be a physician. And I don't know, I think there's a lot of that, altruism of helping people and all that kind of stuff. But I can't pinpoint like the moment where it was like, okay, this is what I want to do. And as I said, I work with kids a lot. So again, went to medical school, gonna do peds, but then wasn't sure. And I decided on combined internal medicine and pediatrics. So med peds. So this is a 4-year residency, and it combines all the requirements of internal medicine and pediatrics. And then at the end of it, you are board eligible for internal medicine and pediatrics. And why is this important? So med peds can do anything almost. You could be a primary care physician and you have all that training in pediatrics, you have all that training in internal medicine, you can take care of anybody in the full spectrum of life doing med peds with the full pediatric knowledge. So family medicine is similar because you still see kids, you still see adults, but you don't get maybe as intense pediatric experience. Like I've spent 3 months of my life in the NICU, I've spent a month of my life in the PICU. I don't know that those are experiences that a family med doctor will get. Med peds is also super cool because of this training. You have the capacity to take care of really niche patient populations. So sickle cell, cystic fibrosis are things that come to mind first. There was a resident colleague of mine who now she did a pulmonology fellowship, not critical care, just pulmonology. And she now runs like the adult CF center here locally. So like that's something super cool that is really med peds kind of oriented, patient care, because you have that, again, full experience of being a pediatrician. You can, other things come to mind, like other conditions that are common in kids that, these kids are now growing into adulthood. And the adult providers are not as familiar with how to care for them or what these conditions are. So med peds really fits that niche really well. Med peds is also great because you could be a hospitalist, again, hospitalist kids, hospitalist adults, and, again, just this full spectrum of care. Mm. Does that answer your question, Dr. Gray?
I think so, but no, let's dive a little deeper. Okay. Are there med peds specialists potentially similar to a quote unquote standard family medicine doc who's out there seeing from the peds population to the adult population, right? You mentioned CF and sickle cell. That makes sense, right? Because that's typically a disease of childhood that obviously hopefully the kid grows up into adults, and then potentially a med peds specialist can continue to take care of those people. I guess the question is, let's use CF here as an example. Mm-hmm. If I am an internal medicine only trained physician, and then I go and do a Pulm fellowship and I want to specialize in CF, I can see my patients. What is the benefit of having peds training at that point?
I would imagine that having the experiences of seeing kids with CF go through what they go through as children and how they got to the place that they are as adults is valuable in that situation. Okay. And I've been, when in residency, you switch back and forth, right? So you like 6 months of peds and 6 months of medicine and 6 months of peds, for the 4 years. Okay. And it's a different vibe on either side, from adult medicine to pediatric medicine. And I can say that walking into a room in the adult hospital of a young adult patient and their mom who were used to, the pediatric team taking care of them, and then now kind of being moved along into the adult world, and having someone know what they had been through and what their pediatric experiences were like that was invaluable to them. Like, they were so happy to have a provider that knew what things were like on the other side, that could help them through this side.
So maybe the question should be, maybe this is a better question. Why doesn't everybody do med peds, and why do we have separate pediatric residencies and separate medicine residencies? Because potentially, I think what you're saying here is the benefit is both from the patient standpoint that, oh, my physician understands me a little bit better. But from the physician standpoint, it's like, I do understand better. I have seen this journey all along the spectrum. Whereas, I mean, you wouldn't know because you are med peds trained, but I mean, from my internship, at least, it was all adults. Like, I didn't see the kids. And so the only exposure that I had to pediatric patients was a few months in medical school. And so it seems like there's a potential benefit for physicians to have a much bigger picture view of a patient's journey, of a patient's life, to say, hey, like, maybe everyone should do med peds instead of separate internal medicine, separate pediatrics. I don't know. Maybe I've come all the way around to that.
I mean, I think like everything, people have their particular interests, and, there's tons of I have palliative care fellows now, and they're like, oh, I have to go see a kid. And I'm like, yeah, you gotta go see a kid. So not everyone, I think, wants to take care of sick kids. And I think a lot of pediatricians don't want to take care of geriatric adults or sick adults. So while I appreciate, yes, you have a more comprehensive view, I think, there's always the right specialty for each individual and what their interests are. And for me, like, I loved kids, but then, the interest of and the complexity of internal medicine was, really, really enticing.
Yeah. Do you think the majority, and I'm sure there's data on this, that the med peds trained physicians are going and doing something very specific? They either go and find their pediatric niche, or they go and find their internal medicine adult niche. I'm sure there's probably very few that are straddling both worlds.
Yeah, I think that those who go into primary care probably do the most of both. And there's certainly, I don't know the numbers, but I'm sure there's a good percentage that, don't subspecialize further and or don't switch to one or the other, and really continue to see both kids and adults. But then there's everyone else, right, who, oh, I want to do a adult subspecialty, or I want to do a pediatric subspecialty. But palliative is really great because it's the same. I mean, it's not the same patients, it's not the same diagnoses, but the concepts are the same. The boards are the same. So palliative is a nice specialty for a med peds trained physician to transition to, because I get to use all of my skills and training in what I do.
Yeah. Interesting. Okay. Let's keep going here then.
All right. So we're going to continue on this journey. So during residency, I decided that I didn't really like primary care. Outpatient medicine stressed me out. I liked the relationships that I had with my patients, but the 15-minute appointments and kind of slogging through your day, didn't love that. So, nearing the end of my third year of my 4 out of residency, I was like, well, I guess I'm just going to be a hospitalist. I didn't really love any subspecialty more than another. I liked taking care of hospitalized patients. I liked complex patients, but I still felt like something was missing. Like, I wasn't thrilled with that career plan, and felt like I just hadn't figured out exactly what it was, but I couldn't figure out what was missing.
Yeah.
So I requested to do an elective for pain management, because that wasn't something that was taught much. I didn't have a lot of experience. We just gave everybody, you know, a milligram of Dilaudid and called it a day. So I was like, I need to do better. So this pain management elective was really a palliative care elective in disguise. My attending on that rotation was dually boarded in pain and palliative, but was really practicing palliative medicine. And I spent a month with her and her team, and like the light bulb went off and I had my moment, and I knew that I had found this missing link. That rotation was all inpatients. They were all complex, and that human connection, that some continuity and in-depth relationship that I was going to miss as a hospitalist, or felt like I was going to miss as a hospitalist, was there. So I decided to do a palliative fellowship. And I want to say again, you know, if you had asked me at any point in medical school and pre-med if I was going to end up doing a palliative care fellowship, I mean, I didn't even know what it was. Like, I didn't know what palliative care was at that point. Like, that was my introduction. I would have said, no, that's definitely not what I was going to do.
Yeah. For someone watching this right now, and again, maybe you have a slide here in a second, what is palliative care? Because
we're going to get to that.
Okay, good.
We're going to get to that. Don't worry.
All right.
All right. So hospice and palliative medicine. Okay. So, I mean, the crux of this specialty is person-centered care for those with advanced illness. And palliative is interesting because it has been a specialty that has had to fight tooth and nail for years and years and years and years to be acknowledged, respected, supported. You know, it's too fluffy. You're like social workers. You're just, you know, holding hands and singing Kumbaya. And that's not at all what it's all about. We do some really complex symptom management. There is an element of support for sure. Having really expert communication around serious illness, around goals of care, around a patient's values. You know, these are all difficult things that we do, focusing on the person and what is right for that particular individual. Palliative is not a individual sport, it's a team sport. So I can't do what I do without my team. So that includes, you know, my colleagues, my physician colleagues, my nurses, social work, chaplaincy, child life support, music and art therapists. Like, everyone has to come together to provide, you know, good palliative medicine. And then it's really a spectrum as well. So, you know, palliative has a bad rap, and people hear the word palliative and they think, oh, I'm dying and I'm going to die in a couple of weeks and this is terrible. And that's not true. You know, I have patients that I followed for years. I have patients who had cancer, who had treatment, who have long-term sequelae of their treatment that are still palliative patients. They still have serious things going on. So palliative is really anyone. Palliative is appropriate for anyone with a serious or advanced illness. And then hospice comes in really at the end of life. So the last 6 months of life are when hospice is appropriate. So thinking about palliative again as a spectrum, and that palliative is all of it, but then hospice is just this one tiny piece of it at the end of someone's life.
Got it.
All right.
I'm just seeing some of the questions here.
Oh, yeah.
About nothing specific what we're talking about yet. So
okay.
Keep rocking.
All right. So so palliative training is only a year, which is also nice. And after doing 4 years of residency, I was like, one more year I can handle, but I don't know that I want to do another, you know, 3. Fellowship training includes, you know, inpatient, outpatient, hospice care, pediatrics, and long-term care. And like I said, you know, the palliative boards are the same for a pediatrician or an adult practitioner. So everyone needs to have the same knowledge, the same skill sets. So peds is important in adults, and adults is important in peds. And then the other thing I wanted to mention here is that to do a hospice and palliative medicine fellowship, you don't have to come from an internal medicine background or a pediatrics background. it's really interesting how much it's expanded in terms of what, folks are interested in palliative are coming from, is what I'm trying to say. So, I'm the program director, so I get all the applications. I see, where folks are coming from, emergency medicine, PM&R, psychiatry, surgery. I have 2 fellows this year that are surgeons. I have 1 fellow coming next year that's a surgeon. So it's really interesting. And I think it's great for the field as a whole to have folks with all these different perspectives and training coming to do palliative care.
Yeah. One of the questions that that comes up potentially just in my mind, because I know a little bit about this, is from a palliative care perspective, like you mentioned a couple surgeons that are coming through the program. Is it that they are like, hey, I don't want to do surgery anymore, I'm going to go do full-time palliative care? Or is it that they recognize the benefit of having this specialized training is for their surgical patients? They're going to continue to be surgeons, and then they have this extra training.
I would say it's both. So our program has had, the 2 surgeons this year. One of them is her long-term career goal is to be a trauma surgeon. So she recognizes the value of having the skill sets in symptom management, communication. And then the other one has been a practicing surgeon and is decided to leave that and just do palliative.
Okay, interesting. Okay. This question may be an interesting one now. Janelle asks, do oncologists share some of their patients with you for palliative care, but then when there's nothing more that can be done, the oncologist pass the patient to you for hospice care? Is that one way of understanding palliative and hospice care?
So I would say that at my institution, myself, my team, we work very closely with our oncology colleagues. So it's not that, we're, in our little silos, we're in our silos a little bit, but, we work collaboratively together. They refer patients. Usually the expectation is that we manage the symptom piece. So, the pain medications, primarily in the outpatient setting, there is an emphasis on, our team having the goals of care discussion, although without the oncology input, that's really challenging. So we're trying to figure out more ways to get them more involved in having those difficult conversations as well. My team and where I work, we don't practice hospice care. So that's a community, organization that, patients then will get referred to when that's appropriate for them. And sometimes the oncologist will still follow a patient in hospice. You don't have to be a hospice and palliative physician to be a hospice physician. You can continue to follow your patient and prescribe medications with support of the hospice nurses and social worker and the team otherwise. And actually in a lot of, especially rural places or less resource places, that's what happens. There's no hospice specific physician. It's just whatever community physician is willing or able to take that responsibility on will do it. I work in a very well-established, well-resourced county that has a not-for-profit hospice, and they have, hospice employees and they have hospice physicians that will take over. I think we try to get away from patients don't want to feel abandoned. So, we try not to, have this very distinct transition where, we're following you and then we're not anymore. So some of my colleagues and myself less so, but sometimes we'll follow patients in hospice as well. So there's no like black and white, often there's not a black and white sort of transition period. It's a lot of collaboration and continuity.
Yeah. I'm not sure how appropriate this question is, just from maybe it's too technical, but the potential difference between a consultant versus an actual treating physician and treating team, is there that differentiation made in general for palliative care teams, or is it maybe a little bit more hospital specific?
I think that's institution specific. I think each, we consult.
Can you explain that a little bit, maybe, for someone who doesn't know what I'm asking?
Sure. So I think it may also depend on the setting. So I'll give you an example. When we see patients in the hospital, we're consultants. So I actually don't write orders for any of the inpatients unless there's a very specific situation that needs to be addressed in that moment and the primary team's not able to, but I don't write orders. I make recommendations. I talk to the services directly about what my recommendations are, but I don't actually order anything for myself. So I am, actually pretty more purely a consultant. As opposed to in the outpatient setting, when I see patients in clinic, they're my patients. So if I, feel like they need a pain medication or whatever that case may be, then I own that and I order them.
Okay. Interesting.
But again, I think that's very institution specific about, what roles you take both in the outpatient and the inpatient setting.
Okay. All right, let's keep rocking.
Right. Okay. So then, my goal when I completed my fellowship was to do pediatric palliative care. That was something that did not exist at all in my community. So the way it worked is I was hired by our hospice organization and then contracted to work in the hospital. And that did not work out very well for me. As a brand new attending, starting a pediatric palliative care program, I had really no mentoring, no support, was getting pulled in a lot of different directions. My employer wanted me to do hospice care, cover people's leaves, cover all kinds of stuff. So I was there for about 2 years. And then my fellowship program director was moving and going to Roswell and recruited me to go with her. So I started at Roswell in 2016, and this is an academic institution. So lots and lots of trainees go through Roswell. We had the fellows and residents start rotating with our team. Our team was expanding. I took on the role as the fellowship associate program director in 2017, and now I'm PD since 2021. And like I said, I mostly see adult patients. There are a few pediatric patients that I see, but my bulk of my patient load are adults.
Okay.
So I wanted to talk a little bit about, what do you get to do as an academic consultant or an academic subspecialist? Because again, if you had asked me or told me, when I was starting medical school or pre-med that I would get to do all of these things, I wouldn't have believed you. So we do inpatient consults. So these are, usually very sick people admitted into the hospital. We probably most frequently get consulted for pain management, but other symptoms, bowel obstructions, refractory nausea and vomiting, delirium, and then goals of care discussions as well. And it's very intense because it's, it's all in this very short period of time. And, the hospital wants you to get people out and fix everything. And there's this expectation that palliative is we're going to wave our magic wands and make everything better. And, but it's very interesting. No day is like any other ever. And then I also spend time in the clinic, and this is a little bit more relaxed in terms of, the acuity of our patients, on, a lot of chronic pain management, cancer-related chronic pain management, symptom management, goals of care, et cetera. When I'm on service, I get to teach fellows. We always have a fellow rotating with us. We get residents, we get internal medicine residents that rotate with us. We have medical students from the University of Buffalo that rotate with us. We get subspecialists from Roswell, so surgical oncology, medical oncology, pediatric oncology, GYN oncology, they all rotate with us. So we have to teach all these different groups of people, which is interesting, trying to teach these different levels of understanding and learning about what we do. I'm responsible for, the fellowship curriculum and all the trainee curriculums. I am the co-chair of our opioid stewardship committee at our institution. So this is really interesting. And I have a slide at the very end, hot topics in palliative medicine, just to give folks a sense of what's interesting and current in palliative care. But opioid management is one of them. There's no guidelines for how you manage opioids for someone with advanced illness. typically palliative is like an exclusion. Like CDC has guidelines for chronic opioid management, but palliative is an exclusion. Like the rules don't apply, but they do apply. So trying to figure out where that balance is and how we're managing opioids and not giving someone, 200 tabs of oxycodone just because they have a cancer diagnosis, kind of thing. So that's a little bit of a passion of mine. My team and I did a actual clinical trial on management of malignant bowel obstruction, which was super cool. We have a paper that we're waiting to have, reviewed and hopefully get published as we speak. I'm a Vital Talk trainer. I don't know if you know what Vital Talk is, but that's a communication tool, framework, if you will. We are teaching all of our colleagues on how to have better communication skills. Like I said, publishing, never thought I would do that. It's super fun. And then just collaborating with people across the country. I'm involved in lots of different projects, and it's really awesome to get to work with people outside your institution and all over the world. Mostly country, but sometimes world. You want me to keep going?
Yeah, let's do it.
Okay. So I wanted to give also a little bit about a day in the life. I know other guests have done this as well. And it's not super exciting. It's a lot of repetition, but when I'm on service every 4 weeks or so. So I can round with our fellows and really get a good sense of what they're doing.
And on service means you're in the hospital versus outpatient.
Correct. In the hospital doing those consults. Yep. Okay. We have a huddle most days with the team. We talk about the patients. This is also an opportunity to kind of reflect and review. Sometimes there's some very difficult, challenging situations. So being able to talk to your team about it and kind of debrief a little bit is helpful. We round with a pharmacist and any of our trainees that we have with us. There's lots of email. We're a very email heavy institution. So that, you look away from your phone for about 5 minutes and there's 20 more emails. So that's like an ongoing through the day kind of thing. We have nurse coordinators that work with our team, and they do triage all day long. So people call, they're having pain, they're not moving their bowels, they're nauseous. Okay, then we got to figure out what we're doing. So there's all these fielding calls throughout the day. I try to do teaching. I try to go for a walk every day if I can. We do family meetings, usually in the afternoons, finish notes, triage, and then I end my day at 3:30, in theory, on a good day. I have a slide here about work-life balance, and I'm actually a mom. That's how I identify first before a physician. I have twins that are 7, so being present with them is super, super important for me. So I have made my schedule such that I get to leave, earlier than everyone else, shortened hours so that I can be with my kids in the afternoon, pick them up for school, that kind of thing.
That's great.
Although work creeps, so not every day.
I'm sure after they go to bed, you're probably charting a little bit.
Yeah, absolutely. So when I'm on service, it's every day, Monday through Friday for that week. On the clinic weeks, I still actually do inpatients on Mondays, and you remember from the beginning, I don't really love clinics, so I've also worked my schedule to do the least amount of clinic as possible. So I do consults on Mondays. Tuesdays and Thursdays, I have administrative time for the fellowship and research and stuff like that. And then Tuesday afternoons, we do our fellowship didactics. Today at 2:30 was emergency medicine and palliative care. So 2 emergency med and palliative med trained physicians were talking about how those 2 specialties intersect. And then I'm in clinic on Wednesdays and Fridays. And I also will say that I'm grateful that I work in an institution that really values palliative medicine and the work that we do. So our clinic appointments are an hour long, which is stellar. It used to be an hour for new patients and half an hour for follow-ups, and honestly the follow-ups take just as long as the new patients do. There's always a lot of things to sift through, symptoms to address, goals of care to discuss. So it seems like it's pretty chill, but it's very emotionally and psychologically draining work. So it's not actually as chill as it sounds, but I have a very good setup and I'm very happy with how my schedule works.
Yeah.
So as I said, I'm a mom. That's important to me. Boundaries are really important to me, and physicians in general are pretty terrible at setting boundaries. At least that's my experience. There will always be more work. There will always be another thing to do, to write, to read, but your family will not always be there. You will not always be there. So having boundaries is super important.
I'm not sure if you'd agree with this, but this whole like, oh, as a physician, you come last, your patients come first. I hate that mentality. I don't know where it came from. I think it is a core piece of a lot of the burnout that we have in our physician workforce. So it sounds like you would agree with that, of like, no, like you put yourself first. And yes, patients are important, but if you're not whole yourself, then you're not going to be great as a physician either.
Yes, I fully agree with that. And, there's institutional push, and I'm sure it says everywhere, that the patient, comes first and you go above and beyond. I'm like, but you can't do that for everybody. Yeah. So how do you pick and choose? Like you can't, so you just do your best. You do your best for everyone, but you have to set boundaries. You have to take care of yourself, because like you said, like if you're not doing that, then you're not going to be able to take care of anybody.
Yeah. Probably beyond the scope for our audience, but I think it'd be potentially important to ask you, for the students who are watching now, they're obviously a few years away from being able to potentially have any say in what that work-life balance looks like, to be able to say like, hey, I have twins, I want to be out of the clinic by 3:00 so I can pick them up, spend the afternoon, whatever. How does someone find an institution that will support them in that way, to say, hey, I know all the other neurologists are fine with 15-minute appointments. The way that I want to practice medicine, I need 25-minute appointments. Like, how does someone who's coming up through training and maybe a new attending find an institution that's going to support them the way that yours has supported you? Or is it just
yeah, I think part of it is being, asking questions. Like if you're interviewing for a job, like asking what the culture is like, asking, what the colleagues' days are like. This is not the situation that I had before I came to Roswell, and this has been an evolving situation since I've been here, but, know what, just understanding the culture. And I think people get so excited, like, oh, I'm going to have a job and it's in the city that I want, and this is great, I'm going to get paid this much, I can pay off my student loans, is awesome. But then you're like, the reality, like people don't ask enough questions about like, what is day-to-day life going to be like? So doing that, and then advocating for yourself. Like I just asked, when I got hired, like, can I have a reduced FTE because my work-life balance is important to me and I want to be there for my kids? And then they said yes. So you just have to, also just advocate for yourself and what your goals are, what your needs are.
Yeah. So when you say reduced FTE, that's a full-time equivalent for those who aren't aware. You're basically saying, hey, can you be flexible with my schedule? I'm a reduced FTE, which means you're comfortable saying, hey, I'll take less pay because I'm working less. So there's some trade-off there.
Yes.
Okay. Got it. All right. Let's keep rocking.
Okay, well, I don't really have a whole lot more.
Okay.
I think, again, just, related to that, balance is like, having support at home, having support at work, and then having healthy coping mechanisms. So many things go to the wayside when you go through medical school and residency because you're so busy, but, continuing to find the time to do, and I feel like this is super cliche, but like finding the time to do the things that make you that make you happy, whether it's exercising or artistic endeavors or whatever it is, like continuing to do that, because that is still really important.
Yeah.
All right, I think this is my last slide, which is hot topics in palliative medicine. So just to get like a sense of what we do, because again, people think it's all like the kumbaya, hand holding, talk about dying stuff. So tons of research happening about cannabis, state dependent, but it's legal in New York, and cool things are happening about cannabis. Ketamine is something that's always interesting. We use ketamine for pain management, for depression. Our clinic got approval to use intranasal ketamine, which is for refractory depression. So pretty like cutting edge kind of medicine. Buprenorphine is also a super, super hot topic in palliative care. And that relates directly to number 2, which is management of patients with substance use disorder and advanced illness. So in the past, envision a patient who has, advanced lung cancer. They've got significant tumor burden. They've got horrible, horrible pain, but also they happen to be addicted to opioids. So then what? Then what do you do? How do you manage them? And palliative is now kind of diving into this niche of taking care of these patients who, as human beings, deserve to have good symptom control, but are super complicated because of the risks associated with their substance use disorder. So buprenorphine is being used very often in a variety of forms and a variety of ways to help take care of these people. I know that a colleague that works at Ohio State, like their palliative clinic has a specific subclinic for patients with substance use disorder and advanced illness, just because they are so complicated. So that's like the national meetings, like there's tons and tons of lectures and topics about, dosing of buprenorphine and this intersection of sort of addiction medicine and palliative care and what's happening with that. As I said, opioid monitoring safety in cancer patients specifically, that's, again, a passion of mine, and there's no guidelines about that. So hopefully sometime in the near future, we'll have something more concrete, but that it's a tricky situation to not limit symptom management, but also be safe with opioids. Psychedelics is a hot topic in palliative care. There's been several lectures at our national meetings about that, for depression, for I think mental health symptoms primarily. And again, thinking about patients who may not have a prognosis that's long enough to allow traditional anxiety and depression medications to work. The SSRIs and stuff take weeks and weeks, and someone may not have that time, so psychedelics work faster. Models of care delivery is another one. So, role of telehealth and palliative care. Can you have an effective goals of care conversation over Zoom? It's hard. It's really hard. Palliative care in the emergency department. So one of my colleagues who just presented at our lecture that, earlier today, she does palliative care consults in the emergency department. She's an emergency department or an ER physician. So, how is palliative care being given? Surgical palliative care, that's also, again, we're seeing all these surgeons who are interested in palliative care for a variety of reasons. So that's a hot topic. And then resiliency. I think there's this expectation that palliative teams are more resilient, and maybe we are. I don't know. Like, you have to be resilient to do what we do. I don't think you could do this work without having, the good coping mechanisms and the support from your team. But with burnout being high, now it's resiliency is the hot topic. It's not burnout anymore. It's resiliency.
Yeah. Same thing, just fancy name.
Different word. But still, there's like this expectation that like palliative is going to come and fix all these problems. I don't know.
Yeah. I'm surprised, and maybe not so much, because palliative isn't necessarily end of life. How much in your world are right to die discussions? I don't think New York is a right to die state. Where I'm at in Colorado, we are right to die. We just went through this as a family. My mom's husband was diagnosed with pancreatic cancer last year. And I was like, we're a right to die state. Have you guys talked about that? And he went and saw his doc and got his meds and actually picked a day that he wanted to leave this world, and he did. And I think it's amazing for a patient to be able to do that. How much is that in your world with palliative care?
So it's not legal in New York State at this point, although I've heard that it's on the horizon. I think, we talk about it because certainly, any palliative care fellow physician should be aware of what that is and what that looks like and some of the ethical things around it. So, we talk about it, but it's not something that I have to think about on a regular basis.
Yeah, interesting. Maria posted, I've been second guessing medicine despite my passion for it because one of my biggest dreams in life is to become a mom. And many people tell you being good at both may not be feasible. Thank you for talking about being a mom and setting boundaries. It made me feel so much better. So thank you for that. For any of you who are listening, if you want to come on and ask a question, you can use a little hand raise feature and I'll allow you to unmute your microphone. You can ask a question. David's coming on real quick here to ask a question. Hello, David.
Hello, Dr. Walter.
Hi, David.
Can you hear me okay?
Yep.
Wonderful. I work in a skilled nursing home, and whenever I see a doctor come in, palliative care or other doctors, I get really giddy and excited. And I had a doctor talk to me about Vital Talk and how it's helped him learn how to have hard conversations with the patient and the families. Can you share a little bit more about your involvement with that?
Sure. So Vital Talk is this national training program, if you will, on how to have difficult conversations. And it's I myself have taken the train the trainer course, so I know how to train other people in this framework. And it's a very concrete sort of set of steps that you have to take to have this conversation. So the first is to reframe. So you want to bring the patient and the family to where you're at in that moment. So they might be thinking about I'm going to get better and I'm going to get more chemo and I'm going to be walking on vacation in 6 months. But the reality is that they're declining with more disease burden and they're not doing well with chemo and they got hospitalized from a side effect. So you want to bring them, the reframe is bring them into this moment. Here we are, you're in the hospital, things are not going well, we're not where we want to be. The second is, and then the piece of that is that you're giving them the information in a concrete way. So they talk about it as a headline. So your cancer is getting worse and I'm worried that we're not going to have any more treatment options. That's a headline. And then you're going to expect that they're going to respond to that, right? No one's going to be happy hearing that. So the second is to expect emotion and then respond to it. So they teach you about, nurse statements. So those are empathic statements that you can use to acknowledge that particular person's emotional experience. So things like, I can't even imagine what you're feeling like right now. That's my favorite one. So this allows you, so the patient or a family member, now okay, now what are we going to do? So the second half of it is figuring out what their goals are, what their values are, aligning with that. So I understand that you want to do X, Y, and Z. And then the last piece is coming up with a plan. So based on what we just talked about, here's what we can do, and then move forward from there. Oftentimes when you're delivering bad news, you end up, no one wants to do it. It's not fun. It doesn't feel good. So people beat around the bush, they go in circles, they talk in medical jargon, and then no one actually gets the information or is able to move forward. So Vital Talk provides this really good structure for how to have that conversation and to move through the bad news and move forward with coming up with a plan.
Wonderful. Thank you so much.
You're so welcome.
Thank you. Anyone else with a question? Raise your hand. Kennedy. Wow. Some poor user design here. Kennedy has a darker skin tone hand raised. but it blends in with the background color
Oh, no.
of the Zoom window. So I'm like, I couldn't see it, but then I saw it. Hello, Kennedy. You can see it there. This like blends in. They need to do a better job of that. Hello, Kennedy.
Sorry about that. I was muted, but thank you all both for your time today. Dr. Walter, I wanted to ask you, with being an osteopathic physician, are there any manual manipulations that you've had to use in any line of your work, at least currently or in the past with your work with palliative care?
So I will be fully transparent and say that I haven't practiced my osteopathic manipulation in a very, very long time. So I do not use it in my current practice.
Thank you.
Yeah. And I think I may be talking off book or out of whatever the word is. I think a large majority of osteopathic physicians don't use any sort of manipulative treatment in their practice. So it's interesting for those who do. Yeah, it's a lower number than I think.
I would say I did, my residency was allopathic, not osteopathic. And I don't actually know if there are any med peds osteopathic programs. So
not anymore, because we're all combined now.
Yes. When I left medical school, I really left the OMM behind.
Yeah, interesting. All right. I think that is it. We'll let you go, Dr. Michelle Walter. Thank you so much for sharing your wisdom today with hospice and palliative care medicine and your journey on through med peds. So I appreciate it.
Well, thank you so much. I really appreciate the opportunity to be here and to speak with you all today.
Yep. Everyone have a wonderful day. Talk to you.
Have a good one.
Bye.
Bye.